to the second round of questions. If any member of the panel would like to make brief, but very brief comment on what have just been said, otherwise we can move to the second round of questions. All right. So then I will go back to you, Raja. So let's dive into the area of zoonotic diseases, surveillance, and pandemic preparedness. With now 75% of emerging infectious disease being zoonotic, in origin and the 2026 One Health Summit in Lyon, reaffirming integrated surveillance commitment, what specific structural reforms are needed to transform the current fragmented human, animal, environment surveillance system into a truly unified early warning platform? And how can Morocco's One Health, a model which you lead, serve as a template for other African nations in detecting and preventing zoonotic spillover events when before even they become pandemics?
Thank you, Ali. This question is critical. It's lies at the heart of global health challenges, but also at the heart of my daily work. So I'm very happy to share with you some reflection I have conducted or still working on with the Moroccan institutions. First of all, to move from fragmented systems to a truly integrated early warning platform, three major transformations are required. The first one is we need first an integrated One Health governance, and we still didn't reach that. That means that we must move from beyond silos between human, animal, and environmental health that requires institutionalized intersectorial coordination, not hot dog collaboration, which is the common work, the common way we are adopting. Shared decision making mechanism across ministries, joint training, joint planning. We have some strategies that adopted this shared decision making, like the national strategy for drug resistance control, but it's the only one. Third is a strong leadership at the highest level of government to be translated at regional and local level, added to clear accountability structures. And we still, improving and moving around this. The second aspect is it has been noticed for the other data is the interoperable surveillance system. Today, data exists, but they do not communicate effectively. And it's the case for drug resistance surveillance between the veterinary sector and the human sector. Data exists, but we cannot connect them. So we need integrated data platform, standardized indicators, and the use of artificial intelligence to detect early signals. It has been done during the COVID. It helped a lot, but we are no more using it on daily basis. We also need to move from this reactive to predictive surveillance. We must anticipate, as you said, risk before the spillover events occur. This implies integrating environmental and climate data, which is not the case, monitoring human-animal ecosystem interface, which is not the case, still the case, and developing predictive models. There is many work on the predictive model, but theoretical model using some experimental data. So I do have a figure, or I have developed an advanced regional sentinel surveillance platform for pandemic anticipation and preparedness that has been shared with the four ministries: Ministry of Health, Ministry of Agriculture, of Environment and Interior, when we have signed the strategic partnership with the association. So it's a model that can be, implemented, transferred, and worked on. And how Morocco can be used as a model for a regional level. I have to say that we are in a good position. Morocco has a unique strategic opportunity to serve as a model. Uh, Instead of all the limitation I have announced, Morocco has an already evolving institutional approach. It has demonstrated strong intersectorial collaboration, particularly during recent health crises, H5N1, COVID-19, the Al Haouz earthquake, and the recent participation to the One Health Summit at Lyon at the highest levels of the government and the parliament representatives. It means that we are on the track and we are taking it seriously. One Health is no more an initiative. It started to be considered as a priority. Morocco is also has a case geostrategic position. We are at the crossroad of Africa, Europe, and the Middle East, and can become a regional One Health surveillance hub. And the advanced Sentinel surveillance platform
Think we are losing the connection with you, Raja. Let's see as we wait for you to connect back, Raja, just for the sake of time, we may move to Philip. And in particular, it looks like it's a little glitch of connection. In particular, one of very important aspect of here you go. You're back, Raja.
yeah, I think there has been some trouble with the connection.
Yeah.
So I was saying that Morocco has a key strategic geostrategic
Mhm.
position, but also what we are witnessing currently is this very important advanced technological capacity. Was what the university UMCSP, University Mohammed V Polytechnic, and the Mohammed V Center for Health Research and Innovation have developed this advanced technological capacities in One Health through integrated platform in precision agriculture, genomics, bioinformatics, artificial intelligence, and many other aspects are very, promising. In addition, these are the demonstrated capabilities and capacities at the Pasteur Institute, the National Institute of Hygiene, the National Office for Health, Food Security and Agriculture, the National Center for Research, Scientific Research, and Technical and Scientific Research, the biopharma. All these capacities are, and many other research laboratories in the private and public universities are very helpful and demonstrating this capacity. How to transfer that to Africa? I have to say that many of the above mentioned laboratories and research units have collaborated for years with Africa, having African students, hosted in the in Moroccan universities and going back with the technology transfer, with the very supportive cooperation to implement, to transfer technologies. So I think there is an opportunity to transfer this model, building capacity, sharing data, and reinforcing original surveillance platform. I think this we are still, discussing and working hardly on this with the Moroccan ministries and the private and the public universities.
Absolutely. Great effort has been done, but still a lot to do.
Yeah.
Now, thank you. Thank you very much, Raja. Let me move back to you, Philip, and in particular in one of very important aspects of also precision medicine, which is the epigenetics and DNA methylation. Your research on epigenetics and DNA methylation has revealed important insights into the interplay between genetic predisposition and environmental factors in metabolic diseases. As we move forward, multi-omic integrations, whether it's genomics, proteomics, metabolomics, transcriptomics, and how can epigenomic profiling be incorporated into clinical decision making for diabetes and obesity management? And if I may follow up, and can DNA methylation patterns serve as actionable biomarkers for predicting treatments responses to, let's say, GLP-1 receptor agonists or emerging obesity therapies?
So first of all, technically speaking, I mean, they have recently a lot of progress in technical aspect of epigenetics. Epigenetics is a mechanism by which aging first and the environment second modify the expression of our gene without changing the structure of our DNA. And that is something that is now more and more possible. For instance, my lab with Illumina developed a new methodology that will be commercialized very soon, named file-based, which means that it is possible to sequence the entire genome and to analyze all the methylation site in a single experiment for a reasonable amount of money. So that is really possible. So technically, we can do the job and to see the epigenetic marks. The difficulty is how useful it is for in clinics. To respond to this question, we work on diabetes because what we do, and especially in the insulin secreting cells of people, really human people, and we analyze the epigenetic landscape, and we analyze two things: the effect of aging, because there are people of different age, and second, the effect of diabetes. If some were diabetes, some were not. It was what we call donors. In fact, the donor is an organ donor. As you can imagine, it's not living people. And what we found was that aging is responsible for an adaptive process that make people surviving to be older by adapting their insulin secretion and how their pancreas works. And that is really well organized and relatively positive. That is interesting. In contrast, diabetes is a kind of catastrophic effect that makes insulin secreting cell ineffective. So that means that today it's impossible to really see the difference between the effect of age, the effect of a disease, and work on the trajectory of chronic disorders that unfortunately for many people are not going to the right direction. One thing we can do is to analyze your cellular age in general. Of course, we don't have direct access to your liver or to your muscle, but yeah, I think in the future, combining proteomics, metabolomics, and genomics, epigenomics, it will be possible really to have a cellular clock of different cells that you can find, or different protein or different metabolite that you can find in your sera. And in this case, it will be very soon possible to have the age of your different organs. If so, of course, the question is what we can do. The only thing I can tell you is that sport is quite efficient to reverse this kind of abnormality due to age. But we don't know extremely well today if any drug can also do the job. But my feeling is it's maybe possible to reverse the effect of age and of disease, and to go back to better epigenetic profile. That I think that in the future is important.
Great. Thank you very much, Philip. I think it's quite interesting, this whole concept of longevity, and perhaps maybe now today we're talking about precision medicine. Perhaps tomorrow we'll talk about longevity medicine. That would be probably the next step. Now back to you, Alan, and let's now focus on the pharmacogenomics implementation in clinical practice. Your identification of the COIP 2C19 variants impact on the response led to FDA. Sorry. Okay. So I don't do this. There you go. That's when you put a lot of exciting questions in front of you, and you wanna address all of them. So that's what happened. So then they continue, led then to FDA mandated box warning and genetic testing recommendations. Despite such compelling evidence, pharmacogenomic testing remains inconsistently adopted in clinical practice. What are the primary systemic barriers? Reimbursement, EHR integration, clinician education, or patient awareness to widespread pharmacogenomic implementation? And how can the German hospital study allowing 95% of patients carry at least one actionable pharmacogenomic variant inform implementation strategies?
Yes. So this is a complicated area. I think that Luca answered a few of these questions more generally, but all of this applies to pharmacogenetics as well. So the first barrier to implementation is developing the evidence base. And for this, the gold standard are randomized clinical trials. There often is not a lot of motivation for the support of randomized clinical trials in pharmacogenomics. Pharma companies are typically not interested in limiting their market through genetics and stratifying populations. And therefore, randomized clinical trials in pharmacogenetics are difficult. That being said, for the antiplatelet therapy example that you've just mentioned, since the initial discovery back in about 2010, there have been 3 randomized clinical trials that do show that genotype-directed antiplatelet therapy is efficacious, and in some studies, cost effectiveness has also been shown. So evidence base is number one. That evidence base then needs to change the standard of care. And the standard of care is usually dictated by professional societies that tend to be very conservative in changing their recommendations, even despite often FDA boxed warnings. And so you need the professional societies to come around and create new guidelines. On the reimbursement side, then, you need to be able to show the health system and insurance companies that there's a return on investment, that if you do the genetic test and pay for it, that downstream there'll be cost savings, or at least it'll be cost neutral with improved efficacy or safety. And that also takes some time. And then we get back to education of the workforce. Physicians and clinicians need to now understand what the new standard of care is, how to order the test, how to interpret the test, et cetera. And then finally, there's the logistics of implementation, not always straightforward. There's the aspect of testing, there's the aspect of getting that result in the electronic health record, building the appropriate decision support for clinicians to be able to appropriately act on a genetic result. The future, I think Luca mentioned, the future is in preemptive pharmacogenetics. Everyone will have their genome sequenced. They'll have all of the actionable variants, including pharmacogenetic variants, already in their electronic health records with appropriate decision support to inform the patient and the clinician throughout their lifetimes.
Wonderful. Thank you very much, Alan. I go back to you, Sonia, and in the topic of AI in drug discovery for diagnosis and treatment. There is a lot of focus on and currently on AI for enabling health innovation. And now with AI achieving about 50% increase in trial access rate, 40% reduction in research timelines, and 25% improvement in treatment planning accuracy. What determine whether health systems successfully adopt AI diagnostics at scale? That's one. And two, what is the potential and what are some of the challenges, including as they relate to equitable progress and meeting the needs of diverse populations?
Thank you. The world of AI divides people, I think, in terms of perspectives. But when we look at AI in healthcare, the potential is substantial, both in terms of diagnosis and treatment and the research and development that goes into that, and in terms of wider health system efficiencies, and of course, R&D and drug discovery. But we also need to be cautious, and we need to be realistic, and we need to distinguish between hope and hype. But let's start with the good stuff first. So if we look at detection and diagnosis, AI has been unleashed. I don't think we're going to put the genie back in the bottle. So it's really how we make the most of it. And it's potential. So if we look at detection and diagnosis, we're already seeing AI being applied to help patients with cancer, for example, breast cancer, skin cancer, and heart disease to get an earlier and a more accurate diagnosis. And it is helping improve detection rates. And then this can potentially enable efficiency gains because it can reduce the workload a doctor has. And because the AI can help rule out patients with a very low risk of cancer or identify patients with a very high risk of cancer, for example, so the clinicians can prioritize those for review. We've already talked a bit about predictive analytics, and AI can also help with predictive analytics and be used as clinical decision support tools for clinicians to make decisions about what treatments are most likely to work best for a particular patient profile, including pharmacogenomics, what types of treatments are least likely to lead to an adverse reaction. So there is a lot of potential, but there's even in some of the areas I've already outlined, there are also concerns because there's a lot of evidence that if you give busy clinicians a tool, they will rely on that tool and they will use that tool. And the real question is, how do we make sure that they also don't not exercise sound clinical judgment? Getting that balance right is really, really important. The other thing I guess that's really important to flag before I go into drug discovery and then into challenges is that there are also a lot of applications from AI that can just help healthcare systems with administrative efficiency. So in the UK, for example, at the moment, there's a lot of focus on ambient voice technologies, which are essentially taking notes when a clinician speaks to a patient. And the idea is that that's going to help the clinician free up time to speak to the patient more and to see more patients. But even there, the devil's in the detail. There's a lot of promise, but these technologies might not recognize people with different accents very well, or, there's a lot of little things to check up on. I could talk an hour about this as well, but I won't. In drug discovery, the idea is that AI is being used to try and improve the accuracy and the efficiency of identifying potential drug targets and informing better treatment design and also smarter clinical trials designs. And in principle, this can help accelerate drug development and potentially increase likelihood of success. And I think there's a lot of potential there. But again, we need to get more granular because the AI is only as good as the data that it's trained on. So the potential for AI to inform better R&D and drug discovery and treatment design is relevant for more mature modalities like small molecules or antibodies, where there's already a lot of existing data and information for the AI to be trained on. Whereas other areas like cell therapy or regenerative medicine, the prospects for AI to be really useful in drug discovery are a long way away. And I also would flag that, I was speaking to a well-known professor who challenged me very appropriately. And he said, using AI in drug discovery may open up so many new questions that we would never have asked in the absence of AI. So whether it will really speed up drug discovery is yet to be seen. It also depends a lot on regulation, like how supportive is regulation of doing more research in silico rather than in animals. And then I guess to your point about the challenges, your second point, the key issues here, of course, appropriate regulation. The US has quite a, innovation permissive approach. The EU has quite a principled and kind of stringent regulatory approach. The UK, AI and healthcare, will have more news soon. We're still working things out, but I think we'll always need to use post-market surveillance. There's a lot of kind of governance and ethics issues to address with like algorithmic bias, the need to regularly update AI platforms and algorithms, and of course, ensure data privacy and security. On the health workforce issues, there's stuff to sort out around workforce acceptability and trust in the AI and workload implications. So on the one hand, the AI can help loads. It can help save time if it's accurate and well integrated. But we need to make sure the analytics are presented in user-friendly ways so that you don't get this like data overload for busy doctors. And to use it safely, as I mentioned earlier, healthcare staff need to be trained on how to use AI in good balance with clinical judgment. And then there's the issue of patient and public trust and inequalities. So if AI isn't trained on data from diverse populations and if it's not used appropriately, it could potentially even increase inequalities. So we really need to think about the data that it's trained on. There's some interesting new technological advances that are being considered, like digital twins or synthetic data to try get that diversity represented. But I think, that's positive news, but we also need more inclusive patient and public involvement and engagement and participation in developing and implementing AI tools, specifically if they're being used in healthcare delivery, not just drug discovery. So yeah, those are just some thoughts I have on AI in healthcare, from diagnosis to R&D to treatment to health services. I hope that's helpful.
Wonderful. Thank you very much. Actually, one of our next programs will be dedicated to AI and industrialization. But let's stay on our topic today. I'll move back to you, Jose. And in the area of ultra rapid NGS, next generation sequencing, for clinical decision making. So Roche's recent achievement of sequencing a complete human genome in under 4 hours signals a new era in rapid genomic analysis. In what clinical scenarios does rapid turnaround genomic testing from days to hours fundamentally change patient outcomes? That's one. And two, how close are we to same-day genomic profiling, guiding real-time treatment decisions in acute oncology settings? And what technical, logistical, and interpretive challenges must still be overcome? Quite a question.
No, thank you for the question. I think from a technological standpoint, rapid sequencing, of course, it's exciting, and we see the developments, and that brings a lot of excitement to the field. But I would position that the key question is not whether we can actually sequence faster. I think the key question is when and in which scenarios that speed changes the clinical decision. And from in an oncology standpoint, I do see several scenarios where turnaround time can fundamentally matter. One is the most difficult one in advanced non-small cell lung cancer, where starting immunotherapy before obtaining a complete biomarker profile, like understanding if there are actionable alterations in EGFR, ALK, RET, MET, BRAF, and TRAC. So without knowing this information, that can complicate treatment sequencing and potentially even expose patients to unnecessary toxicity of certain treatment. Another is on the aggressive hematological malignancies, where genomic information is important for risk stratification of patients, important to inform on target therapy, it's important to inform transplant planning, and also on enrolling and finding eligibility of clinical trials for patients. A third, and a bit more general, is on critical ill patients with advanced cancer, where the treatment window is very narrow because of the fast and progressive decay of patients, which is very fast. And I would say a fourth and last would be at relapse, where rapid tissue testing or a liquid biopsy test can identify what is the mechanism of resistance to the treatment testing provided to the patient. And not just that, but also inform and guide on what could be the next line of therapy. So this is why we really emphasize that time matters in oncology. And going back to the beginning, I don't think the bottleneck is often not the sequencing alone. It's the entire whole pathway from getting the sample to obtaining a clinically meaningful report at the end. So back to your question, if we are close to same-day genomic profiling. Technically, I think we are moving into that direction. And very recently, we launched a sequence giant Orange Nexus system that actually enabled a 24-hour turnaround time. But from a clinical standpoint, the challenge is the entire end-to-end implementation. So having same-day sequencing is very useful, of course, but still we need to account for tissue acquisition, pathological review, nucleic acid extraction, all the molecular biology that is
Losing a little bit the sounds from you, Jose.
Pardon?
But we're following. We're following.
Was it too low or?
We're losing I think the sounds cut.
Okay, so let's see if it gets better.
Sure.
So what I was trying to to convey that from a clinical standpoint, the challenge is the entire end-to-end implementation. Not just the sequencing part. And the barriers to overcome and to reach that are not just technical. They include all the sample logistics, all the sample evaluation with tumor cell content, the assay validation on the laboratory, the reimbursement, the reporting and standards that just alluded in the previous question, the integration with the electronic health records, and also to provide confidence to the clinicians to act on the results. And here, I think we've touched a little bit in previous questions on how clinicians' education, it's fundamental and important to empower them to have that confidence to really act into that. So let's say in the end we need to distinguish between a rapid preliminary information from actually a fully validated clinical report, and this is in a way what drives us every day to make this a reality for global implementation of molecular testing.
Wonderful. Thank you very much, Jose. Actually, there are so many more questions that we could really entertain today, but I realize that we are coming to actually close to the end of our session. It's 1 hour session. So I would like really again to thank you very, very much, each one of you, Philippe, Ala, Raja, Jose, and Sonia, for your wonderful contribution to the program today. Really very rich answers, great expertise shared with the audience. And I'm really glad that you were able to make this first inaugural session of the expert panel as exciting as it could be. Thank you very much again. And to the audience, stay tuned for the next expert panel. Thank you very much. Thank you.
Yeah, that is it. Bye. Thank you very much.
Thank you.
Yeah, bye.